Today, as mentioned, I will be discussing the impact of PSMA PET-CT on the initial management of a prostate cancer, and there is nothing to be disclosed in relevance to this talk. And these are the outlines of my talk. As you may know, that PSMA PET-CT scan has made a very significant impact on the biochemical relapse of prostate cancer. But in the last few years, the role of PSMA PET-CT has increased significantly on the impact of the initial management and the initial scanning and the initial staging of prostate cancer. And this is what I will be discussing in this talk. And the outline will be, I will discuss the possible and the potential impact of PSMA PET-CT on the detection of prostate cancer and biopsy guiding. Also, the focus of my talk will be on the impact of PSMA PET on the initial staging of prostate cancer, starting from the tumor delineation, then to the nodal staging, and then to the metastatic status. Also, I will shed the light on the impact of PSMA on the radiotherapy planning in initial curative treatment and sometimes in the salvage treatment. And I will share with you our KRCC experiences on this regard. So regarding I will start with one of our real life cases that we encounter in our department now, maybe every day. This is a case of 72-year-old gentleman that presented with BSA of 74, Gleason score 7, questionable radiotracer uptake in the sternum on the bone scan. Otherwise, pelvic MRI, abdomen and pelvic CT were unremarkable for lymph node metastasis. So the initial staging on the conventional imaging, including CT and bone scan, it was T3, B, and 0 MX. So this is the MIP image of the prostate cancer, and I believe that most of the nuclear medicine physicians now are aware of this distribution of PSMA, but I will just recap on the physiologic distribution. We see it usually in the lacrimal gland, in the salivary gland, submandibular gland. We see some homogeneous PSMA distribution in the liver, and more intense also homogeneous distribution in the spleen. We see some activity in the bowel, and also it is being excreted in the urinary system through the kidneys and the urinary bladder. And this is the MIP image, and we can see that there is pathologic uptake in the prostate gland itself. We can see many focal of abnormal radiotracer uptake in the abdomen. Potentially there are lymph node metastases. Also, we can see many pathologic uptakes in the mediastinum and supraclavicular regions. So let us together look at the CT scan of this patient, the conventional CT scan. You agree with me that we have some subpathologic lymph nodes according to the CT criteria, not in the right internal iliac. In the retroperitoneal, as we can see, this is 4 millimeters lymph node, as in the upper mediastinum, also small subpathologic lymph nodes according to the CT criteria. But if we look at the PSMA PET fused images, we can see very high expression of PSMA uptake in this right internal iliac, in the retroperitoneal, and in the mediastinum lymph nodes, qualifying them for being metastases from prostate cancer. So the staging was changed significantly from T3B and 0 MX to T3B and 1, as we have pelvic lymph node metastasis, and to M1A, as we have extrapelvic lymph node metastasis. And the treatment changed from surgery and external beam radiotherapy as definitive treatment to hormonal and chemotherapy. The impact of PSMA not only for the initial staging, but also we can monitor the response. We can see that after chemotherapy and hormonal treatment, almost most of these metastatic lymph nodes have resolved and responded significantly. Starting from this, I would like to just give some demographic about the prostate cancer. It is the most common cancer in the developed countries, and it is the third in the developing countries and in the Arab world. It is, according to statistics, 1 out of 9 men will be diagnosed with prostate cancer in their lifetime. And it is among the top 3 killers for men. According to some series, maybe in the Western world, maybe it is #1 killer for men. However, there are many issues and there are many unmet needs in the diagnosis and imaging of prostate cancer. As you know, randomized multiple biopsy is the standard diagnosis, but with low yield, usually about 40% in every biopsy series. and combination with multiparametric MRI has increased the sensitivity to about 70%, but still with limited specificity, not exceeding 50%. So the metastatic spread is hematogenic to bone and lymphatic. As you know, it is about 25%, but in high risk, it may reach about 50% to have metastasis at the initial presentation. We know that the lymph node dissection might be curative, but this is not feasible in about 50%, and it is will not. And this is the main reason why we have early biochemical relapse in the first 2 years after definitive and after curative intent treatment, either surgery or radiotherapy for the initial assessment. And we know that the extended retroperitoneal lymph nodes is very impactful, but it is not visible in many patients. And identifying the oligometastatic status at the initial measurement is very relevant. The metastatic load is very relevant, and it matters, and it would impact the patient's outcome. So, and the biochemical relapse, as I said, it is very common in the about 30 to 50% in the first year after radical treatment. So there are many unmet needs in this very common cancer. And here we have, I believe that there are many rooms for improvement in the recent years. And I believe that the impact of a nuclear medicine has very significant hand in this regard. And here I would like to ask a question that it is almost, we have a pivotal question we have to answer when we go beyond the descriptive statistics of about the imaging techniques. It is very nice to know the data about sensitivity and the specificity, but we have to look at four main elements. One of them is the impact of this imaging modality on the management plan and the impact on the patient outcome, the impact on the quality of life, and also on the cost healthcare. So if the test doesn't have a role in one of these four broad category, it is questionable even if we should go for it. And so we have also to be decisive on what the clinical impact the imaging delivering to the patients. And our champion in this battle against prostate cancer in the Nuclear Medicine Society is the prostate-specific membrane antigen. And it is important to know that this is a type 2 transmembrane glycoprotein with internal and external components. And it is very important when we say that it has an external component that would ligands and link to the targeted tracer, because this enables us to image the viable cells, not like the case of the prostacyclin, which was introduced in the 80s and 90s. And that time it should be only it has an internal, and that time the cell should be dead. It is highly expressed on the surface of prostate cancer, about 100 to 1,000 times more than the normal cells of prostate or the normal physiological distribution in the other organs of the body. It is naturally occurring ligands in secretory cells of prostate epithelium, small intestine, proximal renal tubule, salivary gland, brain, neovasculars, many tumors, and kidneys, bladder, and pancreatic. So it is not 100% specific for prostate cancer, but the expression in a metastatic prostate cancer is much higher than others. It undergoes internalization consequently, resulting in enhanced uptake and retention over time. So delayed image sometimes is feasible, and also this feature enables us to use it for theranostic and for therapy. Also, it is very important to know that it is overexpressed in the androgen independent and metastatic castration-resistant prostate cancer. The level of expression would increase with dedifferentiation, and in metastatic and hormone refractory cancers, the PSMA expression also may increase with androgen deprivation therapy like enzalutamide. Also, the PSMA expression is more likely. Once we have higher PSMA, it is more likely to have a recurrence, and we may encounter some mild increased uptake in benign prostatic hypertrophy, and it can be seen in some other tumors and benign lesions, as I mentioned. Also, the literature is expanding, and actually it is exploding about the PSMA PET-CT. I think it is the most hot topic for publications in the nuclear medicine community. The first publication came in 2012, but now in 2018, it was, for example, about 500. In 2020, it exceeds about 700 publications just about PSMA PET-CT if you go and search the PubMed about this regard. And as I mentioned, I will focus on the imaging and in the initial imaging, but also this is we can use PSMA on the same platform for the theranostic just by switching the radiotracer. As you know, we use gallium-68 and fluorine-18 when we go for the diagnostic part, and we can use the lutetium and actinium when we go for the theranostic type treatment, but this is beyond the scope of this lecture. So it is also, there are many important observations about the role of PSMA and the assessment of PSMA in the initial prostate cancer. It has been found that the overexpression of PSMA correlates very well to the Gaussian score and the PSA level. So once we have higher Gaussian score, it is expected to have higher level of PSMA expression, as well as when we have higher level of PSA, it is expected to have higher level of PSMA expression. Also, it is, as you know, the main role or the modality of choice for the T delineation and the T staging of a prostate cancer is the multiparametric MRI, but it has been found in many recent publications that adding PSMA either in the hybrid modality of BIT MRI or just by using software to fuse the BIT images to MRI has significantly improved the sensitivity and the specificity to the detection and the localization of prostate cancer. As we can see from this publication, which is published in the European Association of Urology Journal, this is the blue line. It shows the performance of multiparametric MRI standalone in the localization of a prostate cancer, initial localization. And when we use the BIT MRI, the result and the performance has improved significantly, and this impacted the performance of this hybrid modality or this hybrid technique in the localization of a prostate cancer. And this would impact for sure the biopsy and the guiding the biopsy. As I mentioned in the introduction, there are just 40 to 50% the yield of the biopsy. So when we have this hybrid technique, this would improve the yield and the accuracy of taking biopsies. Also, another very important question is there any impact of PSMA PET-CT on the T status? Yes, there is a good impact on the extracapsular invasion or extension and on the seminal vesicle invasion. And as you know, this would change the T status to T3B and T3C. And we can see from this also meta-analysis, very important also with significant number of patients, about 10,000 patients only when we look to the multiparametric MRI, the sensitivity and the specificity has improved significantly when we combined the PSMA with the multiparametric MRI, and this has improved the sensitivity and the specificity together. So I would not argue that PSMA would replace the MRI. We know that the resolution provided by the MRI is higher than the PSMA PET-CT scan, but I can argue that adding PSMA PET scan to the results of the MRI would impact the initial assessment of T status of the tumor. Also, we can see this is another publication shed the light on this important topic when we have, for example, in this case, the multiparametric MRI detected the prostate cancer in the left prostatic lobe, but when we added the PSMA, there was another focal of the tumor, and we know that prostate cancer usually presents with multifocality, so the T status was upgraded to T2C. Also, another case with another cases when we can see that the impact of PSMA, it may detect the extracapsular invasion, and this would place the tumor as T3E. And sometimes when we have the seminal vesicle involvement, it would enhance that, it would qualify the tumor to be T3B, and this would have an impact on the management plan of those patients. As we can see in this case, when we have impacted or detected the seminal vesicles involvement by PSMA PET scan. Regarding the nodal staging, the story is different. I can argue now, according to the literature, which has been published in the last 5 years, that PSMA PET-CT is the modality of choice to detect the pelvic and extrapelvic lymph node. Especially in the last 2 years, there have been many important publications, and I will shed the light on this publication. In this meta-analysis, the sensitivity and the specificity of PSMA PET-CT scan has increased significantly, And we can see in many scenarios and in many publications that even very small and very tiny lymph nodes, like 2 to 4 millimeters, can be detected with significant accuracy by PSMA PET-CT scan. Those lymph nodes usually have been subpathologic according to the radiologic criteria, either by CT scan or MRI. Also, at Kinkosen Cancer Center in Jordan, we were from the first group to look at this issue. We have this publication in Molecular Imaging and Biology in 2018, and we investigated the impact of PET-CT in the initial staging of high-risk prostate cancer. Our primary goal was to evaluate the added value of PSMA PET in patients with intermediate and high-risk prostate cancer, and in patients with equivocal radiologic or scintigraphic findings prior to any therapeutic intervention. And we also asked many questions if this modality can potentially replace other imaging modalities. And also we looked at the up and down stagings, and also we searched about the modifying of a treatment plan according to the multidisciplinary decision at our institution. So we compared the PSMA to the CT when we talk about nodal staging and about visceral metastasis, also to the MRI when we talk about the pelvic lymph node metastasis, and to bone scan when we talked about the bone metastasis. So this is another case from our study. This is a 64-year-old patient, a new case of prostate cancer with PSA 14 and a Gaussian score of 9, CT scan concerning prominent retroperitoneal and mediastinal lymph node, and the negative bone scan. So when we look at this scan, we can see that there was many abnormal or pathologic uptake in the right scapula and in many ribs, and at that time the bone scan was negative, and so PSMA changed the staging and excluded, first of all, it excluded the lymph node metastasis. As we can see, these mediastinal lymph nodes, there was no uptake, but also we confirmed the 3 bone metastases missed by bone scan, and the treatment plan was changed to hormonal treatment. So another case, a 73-year-old patient presented as a new case of prostate cancer. The Gaussian score was 9 and PSA was 20. The initial staging was T3A M1, as it was suspected to have right liver lobe metastasis, and the plan was to treat the patient by chemotherapy and hormonal treatment. However, based on the PSMA PET scan, we excluded this hepatic metastasis, but also at the same time, we could detect a very tiny perirectal and internal or obturator, left obturator lymph nodes. So the staging also, it was changed from N0 to N1A, as we have many pelvic lymph node metastases, and external beam radiotherapy with curative intent was applied, as well as to hormonal treatment. So this was patient changed from palliative to curative intent treatment. When we compared, we had shown that PSMA has higher accuracy than MRI in detecting suspicious pelvic lymph node metastasis with significant p-value. Also, the performance of PSMA was better than CT scan in accuracy in detection of pelvic and extrapelvic lymph nodes, as well as visceral metastasis, very important with very significant impact value. Also, the performance exceeds the performance of bone scan in detection of bone metastasis with 95 compared to 75 accuracy. So we concluded that PSMA seemed to be an invaluable imaging modality in the assessment of primary prostate cancer, with a great potential for detection of lymph node spread and bone metastasis that would impact the management plan of the patients. And we suggest that more prospective trials are needed. This was, as I mentioned, from the first studies discussing this issue. Another important publication came also in 2019 regarding the bone metastasis or bone staging. In this modality, it is, as you know, there is a very good argument that the whole body MRI is the best modality to detect bone metastasis. Also, there are many institutions with good experience sodium fluoride PET-CT. So this study compared in 55 patients the performance of PSMA PET-CT scan with histopathologic final diagnosis for most of these lesions. And the higher hand in this study also was for PSMA PET-CT scan, with almost concordance result with 54 patients out of 55. Only one patient who was thought to have only diffuse metastasis, but he had actually 1 to 5 metastases. But the performance of PSMA PET-CT exceeded the performance of whole body MRI, as well as the sodium fluoride PET-CT, and it was the best modality for staging of bone metastasis. Another very important publication came in Lancet Oncology in 2020, which is considered a paradigm shift or a paradigm changing publication. It is a prospective phase 3 trials in Australia, multi-institutionals, and they looked about the impact of PSMA PET-CT scan on the initial staging of prostate cancer with a crossover design trial. So they investigated about 339 patients who had a PSA more than 20 and T stage and T stage more than T3 or equal to T3. They were put in two arms, the conventional arms and the investigational arms by PSMA PET-CT scan, with crossover design for the cases with positive findings. And the reference standard was histopathology in significant number of those patients, along of multiple soft criteria like the follow-up imaging and the outcome of treatment, the level of PSA, and many others. They set a target to have 10% improvement as a statistical analysis to call this trial positive. But actually they achieved much higher and very impressive results, with overall accuracy of 92% for the investigational PSMA PET-CT arm compared to the conventional and standard CT scan and bone scan. And if you look in numbers, the PSMA PET-CT sensitivity was 85 compared to 38, and the specificity was 98 compared to 91. So the accuracy was much better. It is not about only the sensitivity and the specificity, but this trial also showed that there is a greater treatment impact, fewer uncertain results, with less radiation exposures and higher report agreements and consensus, and no adverse effect at all. So this study has shown the very significant impact of PSMA, and as I mentioned, this study has the potential to change most of the guidelines in the initial staging of high-risk prostate cancer, and will be adopted in many guidelines in the early future. Also, there have been many aspects discussed in the role of PSMA in the initial management. One of them is about the superior predictive value for surgical resection when compared to Gleason score and PSA at time of imaging. And this has been shown in few studies. Also, the extra prostatic disease identified on staging and pre-operating PSMA is independent predictive of poor surgical response to radiotherapy, and this also has been shown. Also, the very important topic that is being discussed nowadays is the oligometastasis and the oligometastatectomy sometimes, and it has been shown that PSMA PET-CT scan is the best modality when we would like to detect this status of oligometastasis, which is considered an intermediate status between the metastatic disease and the local disease, with curative intent treatment can be directed for those patients. Also, it has been shown that the SUV max of shown by PSMA in the primary tumor has a relation with the Gleason score and the metastatic extent of disease, as well as the PSA level defining the prognosis. Another very important aspect on impact of PSMA is the radiotherapy treatment plan. And we have recently published this paper. It was just this month in March. It was published in the Nuclear Medicine Communication about our experience at King Hussein Cancer Center and the influence of the PSMA PET-CT scan on the prostate cancer staging and the planning of definitive radiotherapy, either in initial radiotherapy planning or as a curative salvage treatment after biochemical relapse. And this is one of our cases that the impact of PSMA PET-CT scan as the same story of the having these perirectal and this presacral small lymph nodes that would be overlooked by other modalities. But when we target this by radiotherapy planning, the impact was very significant, and those patients has achieved a significant decline with PSA and good control on the follow-up. Another case, when we have this case of oligometastasis metastatic, for example, this is sclerotic lesion in the sternum that was missed by bone scan, but we can direct radiotherapy to this lesion, and this patient has significant decline in the PSA after this treatment. So we concluded from this recently published trial that PSMA has better accuracy in detecting prostate cancer sites when compared to conventional imaging, and this superiority helps the treating radiation oncologists to better define the actual extent of the disease. Also, it was in our cohort that the staging was changed in 36% compared to the conventional staging, and we identified disease locations, helped radiation oncologists to define the radiation target volume, and the rate of change in radiation planning reached about 31%, and in 10%, the aim of a treatment changed from palliation to radical intent in case of oligometastasis, and the most frequent changes in radiation field was including of the pelvic lymph nodes, as well as in some cases, the oligometastasis in the bone. And moreover, PSMA improved detection of oligometastatic status in 6.4, and these lesions were targeted with SPRT with potential radical intent. Also, the last I would like to highlight in this talk is about the harmonization of reporting. As we know, there is the PIRAD, and for the MRI, also now there is a suggestion about to have PSMA RADs scored by 1 to 5 about this would reflect the level of PSMA expression and the anatomical localization and the anatomical correlation of PSMA. This is a new experience. It needs more verification and it needs more publication, but these are good trials. And I think if this being duplicated in more studies and more trials will be standardized and should be also adopted by the international societies, for example, like European Association or IEA, to give it more harmony. Also, there was a very good suggestion from the PROMIS. This also was published in the European Journal of Nuclear Medicine 2018 about the impact, how we can categorize the PSMA PET-CT finding. I would like to hide this slide. It's very important when we have single focus in single loop, we can do molecular imaging T2. When we have bilaterality and multifocality, this would be T2M, and when we have extra capsular invasion, this would be T3A. When we have seminal vesicles involvement, will be T3B, and when we have organ involvement like urine bladder or the rectum, it would be T4. And sometimes after radical prostatectomy, if we have an uptake, PSMA uptake in prostatic bed, this would be molecular imaging TR. Also, regarding the lymph node staging, if we have only one lymph node, this would facilitate the concept of treatment for oligometastasis. We will have M1B, and when we have also multifocal with uni, and when we have multiple lymph nodes in the pelvis, would be oligo less than 3, and when we have extra pelvic or retroperitoneal, this will be M1B, and sometimes when we have organ, it would be disseminated disease. Also, the same concept for the bone scan, we have to identify in our report if we have only single lesion or oligometastatic lesions or multiple lesions or diffuse bone metastasis. It is nice to adopt such criteria in our reports, but we have to communicate very well with the oncologist to make a harmonization and to make a better understanding language between the nuclear medicine physicians and oncologists to have good impact on the patient outcome at the end. And thank you for your attention.